Hello and welcome to today's Center for Healthcare Strategies webinar, made possible by the Robert Wood Johnson Foundation on catalyzing Medicaid-Public health collaboration to achieve mutual prevention goals. Lessons from CDC's 618 initiative. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be one moderated question and answer session during today's presentation. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I will now turn the webinar over to Shilpa Patel, Senior Program Officer at the Center for Healthcare Strategies.
Thanks, Travis. Good afternoon, everyone, and welcome to today's 618 Initiative webinar. My name is Shilpa Patel, and I'm a Senior Program Officer with the Center for Healthcare Strategies, or CHCS, and I'll be moderating this webinar, made possible by support from the Robert Wood Johnson Foundation. This webinar will describe CDC's 618 initiative and highlight accomplishments from participating Medicaid-Public health teams. The webinar will also include presentations from the New Hampshire and Kentucky Medicaid-Public health teams, who will discuss their collaborative efforts and successes in reducing tobacco use and preventing type 2 diabetes within the 618 initiative. The webinar will also describe a new opportunity for Medicaid-Public health teams to receive technical assistance under the 618 initiative to advance prevention in their states. At this point, I'd like to introduce our presenters. Our first presenter will be Michi Knight, a Program Officer at Robert Wood Johnson Foundation, who will provide opening remarks. We will then hear from Tricia McGinnis, Executive Vice President and Chief Program Officer at the Center for Healthcare Strategies, who will provide an overview of the 618 initiative and highlight accomplishments from participating Medicaid-Public health teams. Tricia will then turn it over to Kristen Bruce Willis, a Senior Public Health Advisor with CDC, and Deirdre Stockman, Technical Director for Quality Improvement at CMS, who will offer their perspective on the value of 618. We will then hear a presentation from the New Hampshire team about their recent work to reduce tobacco use and the Kentucky team about their work to prevent type 2 diabetes. We will end the webinar with information on a new 618 technical assistance opportunity, where I will go through the timeline and selection process. I've gone through most of the agenda, but as Travis noted, you will be able to ask questions throughout the webinar via the Q&A chat function, and we will address them at various question and answer sections of the webinar. I'll now turn it over to Michi Knight from the Robert Wood Johnson Foundation for some introductory remarks.
Thank you, Shilpa. And I'm coming to you live from Chicago Airport, so please pardon any interruptions. I wanted to echo the thanks for joining us today on the webinar, and especially to thank CHCS and CDC, who are partners among many other partners in this work with RWJF. As Shilpa mentioned, I'm Michi Knight, and I'm a Program Officer at the Robert Wood Johnson Foundation. My goal today is to do three things very quickly and to get you back to the main event. One, to tell you a little about RWJF, to tell you where 618 fits into our strategic priorities and why we're excited to continue our support of this work. And I'll close with an ask that exemplifies one of the ways we're committed to operationalizing equity in our work, in this work with you as part of 618 and the work that we support in general. So here we go. RWJF is the largest philanthropy in the U.S. dedicated solely to improving health. We set a big, bold vision to build a culture of health in America. Essentially, this vision is about helping to create a society where good health is a fundamental value that guides the decisions that impact all of us. Our utmost aim is to provide a fair and just opportunity for everyone to achieve their optimal health. Our vision and these values lead us to seek bold and lasting change in the efforts that we fund. So one of the strategies RWJF is focused on is strengthening the connectedness of different systems so that they can better address the holistic needs and goals of the people and advance health equity. We believe the 618 initiative can be instrumental in supporting this strategy, especially as it relates to 4 core principles or pillars that we've prioritized. And those 4 pillars are: 1, shared vision and goals across sectors. For example, 618 helps Medicaid and public health teams understand each other's priorities, pain points, and can help to identify win-win opportunities to advance your shared aims. 2, shared data and measurement. 618 can help deepen the understanding of Medicaid and public health data-related assets that can inform population health efforts. 3, sustainable financing with accountability. Medicaid and public health teams, through the 618 initiative, can bring together payment approaches such as value-based payment with prevention strategies. And 4, there are opportunities to formalize your relationships, for example, by establishing shared governance structures. So we are clear-eyed that systems alignment is not easy, but leveraging our resources to greater synergies and shared outcomes are common interests. So our continued support of the 618 initiative is one of the ways we can help foster stronger, sustainable connections across Medicaid and public health agencies. As we at RWJF continue to learn our way forward in advancing health equity, we aim to be more diligent and deliberate in ensuring the voice and participation of people who are most impacted are part of shaping solutions to the problems they face. In this work and in all your work, I challenge you to consider how you can do the same. I look forward to being in relationship with you, to supporting you in your endeavors to address equity, to advance your shared goals and priorities. And I look forward to continuing to think about what the challenges are that you face and how we can provide the supports that you need to overcome them. I thank you all for what you do to build a culture of health in your respective communities, in your states, and in your territories. So with that, I'm signing off, turning over to Shilpa. I'll be on for another little while, but as I mentioned, I will have to sign off as I'm at the airport and heading out on a flight shortly. Shilpa?
Thanks, Nishi, and safe travels. So I'll now turn it over to Tricia to give an overview of the 618 initiative and highlight accomplishments.
Thank you, and thank you, Mishi, for that great introduction. My name is Tricia McGinnis, and I'm with the Center for Healthcare Strategies, and I also just want to thank our partners on the phone today, CDC, CMS, and our partners in Kentucky and New Hampshire. I'm going to quickly give a very high-level overview of what the CDC 618 initiative is, in particular, how it relates to state Medicaid and public health agencies working together. So 618 is an initiative that is led by the CDC, and it really is focused on promoting the adoption of evidence-based interventions by bringing together healthcare purchasers, payers, and public health into collaboration around implementation. The 618 initiative, it focuses on 6 common and high-cost health conditions, and those include tobacco use, high blood pressure, inappropriate antibiotic use, asthma, unintended pregnancies, and type 2 diabetes, and 18 associated interventions that have a strong evidence base for improved health outcomes and cost reduction or neutrality. So when CDC developed this initiative, they used five really important criteria to select those conditions and those evidence-based interventions. The first was that the health conditions had to affect a large number of people and were associated with high costs. Second, the interventions are specific and relatively underutilized now across the country. Third, the interventions, that they are interventions that prevent or control a condition and yield short-term savings. And finally, these are interventions that can be implemented in both a clinical and a community setting. So really looking at ways to bring the evidence base together and combine what payers do well and what public health does well to really promote population health. Next slide, please. So there are 2 primary goals that we have in this initiative, as Mishi noted. First and foremost is to improve the health and control costs using specific evidence-based interventions. That's the most near-term goal. But the secondary goal, as Mishi mentioned, is really to help establish sustainable cross-sector partnerships between public health and healthcare purchasers. And in this case, with this initiative, specifically between Medicaid and public health departments at the state agency level. As we all know, as we in the healthcare sector embark to improve quality and lower costs, that involves not just how care is delivered in the clinical setting, but what goes on outside the clinical setting in the neighborhoods and homes in which people live, work, and enjoy their lives. And given that, in order to be successful in bringing those interventions to bear, it really is incumbent upon cross-sector collaboration, both at the agency level as well as at the provider, healthcare purchaser, and community level as well. And 618 really is about helping state agencies create those skills to do so while implementing these evidence-based interventions. Next slide, please. So why are we finding such great interest among the states, territories, and communities who are adopting the 618 intervention? What we're finding is that this really resonates and aligns with state quality improvement goals that are in place both at the Medicaid level and at the public health level. And this really creates an opportunity for Medicaid and public health to work together on shared population health priorities. Second, the 618 initiative, because of the evidence base around both quality improvement and cost containment or control, can be a really effective mechanism for accelerating the impact of value-based payment reform efforts that most, if not all, state Medicaid agencies are undertaking and prioritizing today. And finally, states are joining because it's hard really developing cross-agency, cross-sector collaboration. But 618 is a really practical, concrete way for states to really either strengthen existing partnerships or to begin to build new partnerships. And with that, in the interest of time, I'm going to hand it over to my colleagues, Kristen Bruce-Walis at CDC and Deirdre Stockman at CMCS, to share their thoughts around the priorities and the impact that 618 is having. So Kristen, take it away.
Great, thanks, Tricia. So from our perspective, the increased alignment between healthcare quality and payment has really provided a new opportunity for public health and healthcare sectors to work together. And CDC 618 initiative really provides an opportunity for public health and Medicaid to collaborate on improving health and healthcare cost outcomes. The 618 initiative has really helped provide a set of rigorous evidence around some of these high-burden health conditions and the related clinical interventions, and that's the 6 and the 18. We've been able to highlight disease prevention interventions to increase coverage and use and quality of these interventions. We've tried to work to align proven prevention practices with value-based ways of paying for health care. And in addition, the 618 intervention really aligns with CDC's work around prevention and activities that state public health departments and programs are actually supported and funded by CDC categorical programs. So it aligns very directly with that work and helps support that work. Our CDC technical assistance support is directly provided by our programs. And over the last 3 years, public health and Medicaid teams have really, what we've seen, learned a lot about how to work with each other and sort of what the complementary roles are and the strategies that they can look to sustain those partnerships sort of beyond the 6 and 18 clinical interventions. So it's really provided an opportunity for learning on both sides and greater collaboration. So we're really excited for at CDC to see this work continue in another year and to work with our partners, and we greatly value the partnerships, especially the partnership that this has provided for us to work with Medicaid. And with that, I'll hand it over to Deirdre.
Thanks so much, Kristen. And I'm here to say that the Center for Medicaid and CHIP Services at CMS is really pleased to have been a partner with the 618 initiative since the beginning and going into its 4th year. Guided by the CMS strategic priorities of focusing on results and unleashing innovation to make sure that beneficiaries get the right care at the right time, at the right place, and that providers and health plans deliver better care at lower costs. The Center for Medicaid and CHIP Services, or CMCS, at CMS, partners with states to share best practices and provide technical assistance to improve quality of care. A particular emphasis of our quality technical assistance to all states is on collecting and reporting to CMS the Medicaid and CHIP core set measures and using those measures to drive improvement. As you may know, we have two core sets of measures, one for children and one for adults, and both measure sets include measures related to 618 conditions. There are multiple measures related to asthma care and outcomes, including the asthma medication ratio in both the child and adult core sets and the asthma admission rate. The adult core set also includes a measure of tobacco cessation and controlling high blood pressure. And as you know, the conditions that these quality measures address, asthma, tobacco-related disease, and hypertension, impose significant costs on the health outcomes of Medicaid beneficiaries and on state Medicaid budgets. But many of those poor outcomes and costs can be avoided or reduced through improved care. We think 618 can play a key role in helping state Medicaid agencies and their partners in public health and other state health offices focus your limited time and resources on interventions that have been proven to improve health outcomes for people while being cost-effective for the state. I kind of think of it as 618. The 618 team has done a lot of the homework, the initial work, and made it ready for states to take and implement. So expanding access to the evidence-based interventions that are part of 618 has the potential to help drive improvements in state performance on these quality measures, as well on the core sets, as well as other measures of importance to the state. So CMCS looks forward to the work continuing in the coming year and getting to know new states and getting to know old states better as the work continues. Thanks so much.
Thank you, Kristen and Deirdre. We will now hear from two Medicaid public health teams about their experience in the 618 initiative. First, from New Hampshire, we will hear from Jane Hybush, an administrator in the New Hampshire Medicaid Medical Services Coverage and Benefits Unit, and Teresa Brown, a tobacco treatment specialist in the Division of Public Health Services Tobacco Prevention and Cessation Program. Jane and Teresa, the floor is yours.
Great, thank you. On behalf of the Department of Health and Human Services, I would like to thank you for allowing New Hampshire to present this afternoon. My name is Jane Hybush, and I'm the administrator for Medicaid's Medical Services Unit, which includes coverage and benefits alignment. And the individual who was also part of our Medicaid team was Henry Littman, who is our Medicaid director. I'm going to let Teresa Brown introduce the public health team.
Thank you, Jane. Good afternoon, everyone, and thank you for allowing us to talk to you folks and share our experience. I'm going to introduce the Division of Public Health Services team, which is under the umbrella of New Hampshire Department of Health and Human Services. Sai Shirala is our Bureau Chief of Population and Community Services. She could not be with us today, but she is a big champion and has been a big champion of tobacco treatment amongst the populations who most need it. Donna Asbury is the Tobacco Prevention and Cessation Program Administrator, who sort of guides the program in all the activities that we complete. And I am a tobacco treatment specialist, and I manage the state quit line, Quit Now, New Hampshire, and I work on most activities that have to do with cessation. I'm going to go on to cover, I think you want to just advance Travis, if you could advance the slide one, I think. Yeah, there we go. I just want to put that on the screen so you folks can follow along with the 618 goal that we came up with. The goal is to reduce tobacco use among New Hampshire-made population using strategies to improve accessibility to cessation medications and reduce barriers. In 2017 to 2018, the Office of Medicaid reprocurement process for the Medicaid managed care organizations really set the stage for this collaborative effort that came out over the next year. And the interagency work group that was developed focused on expanding the cessation benefit from exclusively pregnant women at one time to the entire Medicaid population. And this was important because as the state MCOs came on board, we wanted to make sure that everyone had access to the evidence-based tobacco treatment. And then out of that interagency work group, the application to the Center for Healthcare Strategies came about, and then the award for 618, and that puts us here. We couldn't be more pleased about the technical assistance and we received from the team at CHCS.
Okay, so Travis, could you advance the slide, please? This is Jane. I'm going to talk a little bit about the key activities that we undertook during this initiative. One of the things I think was really important for us was we looked at creating a work plan to assess the language that was in the current MCO contract, and also looked at utilization of the Medicaid cessation medication benefit for both our two managed care plans, WellSense and New Hampshire Healthy Families, and fee-for-service. That really set a level for us all in understanding what each of the activities was included and making sure that it was all aligned so that we were doing all the same thing. I think the thing that was really most important for us was the research that we did with collaboration with public health on the model contract language to place tobacco cessation within the Medicaid MCO request for proposals. And I think placing that in an important component part in making sure that our managed care plans were going to be implementing a robust tobacco cessation benefit. Here in New Hampshire, about 99% of our membership is enrolled in a managed care plan, so all the more reason for us to make sure that we're providing, a management and oversight and monitoring of the tobacco cessation benefit that's being provided to members via the managed care plans. We also reached out to other agencies to provide us with technical assistance as we were crafting the model contract language. I think our major accomplishment has been the agreement to engage in collaboration between the Division of Medicaid Services and the Division of Public Health Services. We are continuing to work together on expanding and providing a more robust tobacco cessation benefit in light of the vaping issues that we have going on, and I think it's presented an opportunity for us to, leverage resources within Medicaid as well as public health. We did include comprehensive evidence-based tobacco cessation language in the request for proposals and are monitoring currently what it is from a claims perspective that the managed care plans are providing so that we can re-engage them to say, this is what we know that you're paying, this is what your contract says, and make sure that those activities are aligned. The other activity that we are looking at is that we certainly understand from a managed care perspective the importance of allowing our managed care plans to have utilization management controls within their prior authorization activities, but we will be asking the managed care plans to tell us about their experience with tobacco cessation pharmaceuticals relative to prior authorization and how many approvals and how many denials were done, because obviously if the managed care plans are approving most of the prior authorization requests, there becomes an issue about whether or not prior authorization should continue. And I'll turn it back over to Teresa.
Super, thank you. This is Teresa, and I'm going to cover, let's see, do you want to advance? There you go. Thank you for advancing that slide. The Tobacco Prevention and Cessation Program enlisted the help of our epidemiologists to look at the all payers claim database, who is housed with a subcontractor, University of New Hampshire. And what we were looking at was trying to get a bead on the current utilization of the CPT codes 99406 and 99407, which is the counseling codes used for a short counseling session 99406 and a longer counseling session 99407. So we looked at that data to find out exactly what the utilization of these codes were for the past 2 years, and they were fairly low. So we knew we had a lot of improving that could be done. And we were fortunate enough to have the assistance of the North American Quitline Consortium to help us with through the public-private partnership work group headed up by Deb Osborne. New Hampshire was one of the initial states to enter into that, and we participate in monthly calls and one-on-one sessions with Deb and American Lung Association, Ann DiGiulio, and the CDC representative Anna Schechter has really given us some really great language and has refined our language and set the tobacco program up to have some successful language inserted into the RFP and now into the contract. And the Medicaid services will provide later in the future provide an update as relative to the prior authorization utilization, and I think Jane just spoke to that. And then we will have that information under our belts to assist us with determining the next steps regarding where we're going to go with prior authorization for cessation medications. Our next steps in terms of moving forward through the Medicaid process to get the tobacco treatment cessation benefit operationalized, so to speak, is the Tobacco Prevention Cessation Program has worked to create a guidance document that will describe the implementation tasks and actions that will sustain patient-centered care and give a high value to the care that is going to be given through that benefit. And the guidance document has been developed to offer very robust language that will help guide the MCO in the evidence-based direction, as well as some performance measures and benefit promotion. So we all know that if a benefit is not promoted, the utilization of that benefit will not really have high value. So what we really are working on is to continue the collaboration in respect to promoting the benefit widely to not only to the members, but to the providers. The tobacco program will also offer technical assistance to the disease management section of each MCO, as well as to the network providers. And then as we go along in this process, and the guidance document is accepted and moved into a final stage, we'll assess the readiness to move forward perhaps, or at this time perhaps not, looking at the state plan to enhance the Medicaid cessation benefit. Again, at this time, we have taken some great first steps, and there's so many steps to come, but we're trying to be very methodical and thoughtful as this process moves forward.
Travis, can you advance the next slide? Yep. Okay. So lessons learned and next steps. I think the most important lesson learned for us relative to our work on the 618 initiative is really the getting to know each other as part of the process. Many times because of the work that's being done both in the Medicaid program and public health, we get consumed with our own approaches in terms of working on, benefit designs and other sorts of activities. And I think that this initiative allowed us to work together to get to know each other, and then to really think about brainstorming around how we can sustain some of the efforts utilizing the best practices from public health and applying them in the managed care arena. So I definitely think the quality team approach has really sustained our efforts relative to making sure that we look at tobacco cessation, but also that we also have the opportunity to look at other chronic conditions that affect our Medicaid population, to see what other initiatives can we utilize and use public health expertise to train and provide some monitoring and oversight of our managed care plans. So again, next steps were investigating the need whether or not we need to do a state plan amendment in order to expand our counseling activities in Medicaid. One of the things we want to do as well is to have our colleagues in public health understand better the MCO performance measures that we have identified for ongoing monitoring and, again, performance measurements. And public health will be sharing with our managed care colleagues as well as with the Medicaid program about performance measures from the quit line so that we're understanding sort of where we need to shore up some activities. And I think that has been, sort of a summary of our next steps. So anything else, Teresa?
I think what I really would like to put out there is a big thank you to CHCS and a shout out to all you folks for helping us. We all have so much on our plates with our regular work that this collaborative effort really helped us open our eyes as to the amount of work each other does on a daily basis and the real commitment we have to this population for improving health any way we can. And no matter how detailed we think we might be towards instructions or information back and forth, it really is a matter of getting down to the details and open communication, and this collaboration has been nothing but, in my opinion, a positive interaction, and I'm looking forward to the future with this project. Thank you.
And this is Jane, and I would echo that. So thank you again for allowing us the opportunity to present this afternoon.
Thank you so much, Jane and Teresa. We will now hear from the Kentucky team who will present on their work to prevent type 2 diabetes as part of the 618 initiative. From Kentucky, presenters include Stephanie Bates, the Deputy Commissioner at the Kentucky Department for Medicaid Services, and Connie White, Senior Deputy Commissioner at the Kentucky Department for Public Health. Stephanie and Connie, please take it away.
Good afternoon, everyone. Greetings from Kentucky on this beautiful fall day. We're very excited to share our work that we have been doing on diabetes between Department for Public Health and Department for Medicaid Services. So we've got so much we want to cover. I'm going to go ahead and let Stephanie get started with the next slide.
So, good afternoon. My name is Stephanie Bates. As said before, I'm the Deputy Commissioner for Medicaid, and so we are really excited about our partnership with Public Health. And what I didn't realize was unusual is that we actually have had a long-standing, very close relationship with the Department for Public Health on other issues. So this collaboration was really easy from the beginning. So it's really nice to have that collaboration and the relationship. And so one of the things that we've been excited about within Medicaid, and so I'll back up and just say that the diabetes prevention program, as it is with the state, is not covered in Medicaid, and so that's one of the things we were looking at to cover. And so we had one of our MCOs. We have 5 MCOs who decided to do a pilot. Now, that pilot finally got kicked off in mid-June of this year, and the pilot mainly focused in our 2 biggest cities, Louisville and Lexington, Kentucky, and it was basically with 4 FQHCs. And I'll tell you that the uptake of the program really was slow. We thought for sure that it would be a popular pilot and that there would be a lot of participation. But what we found was that the barrier so far, and this is kind of actually, now that we are further into it, it makes a little bit more sense. But the barrier that we see now with this, and it's Humana as who's doing this pilot for us, is the referrals. We're not getting referrals from providers. And that is actually kind of a long-standing Medicaid problem anyway. So, but we have gotten through part of it. It's been slow on the uptake, and we're excited about that. Now, outside of that pilot, I will say, and the previous presentation talked about an MCO RFP. We are currently in the middle of an MCO procurement. And as part of that, there is really a big push for certain quality measures in certain conditions, diabetes being one. And so we expect to see much more interest, and I'll talk a little bit later when we get further into the presentation about some things that we're doing, but we will start to see more of these pilots come on. So just wanted to kind of put that out there. And our biggest barrier in Kentucky for not covering DPP right now is that, one, it's not in the state plan, and two, the way that our provider enrollment is set up is we have a hard time identifying a provider type and diagnosis to consider this medically necessary. And so through the pilot, we're hoping to learn as much as we can about how the flow of the claims and the tracking work. As we know, Medicaid beneficiaries have a reputation for being non-compliant, so how do you deal with that and still get the provider paid? So again, we're really excited about this pilot, a little disappointed at how slow it's going, but we do expect to see in general across our entire Medicaid program a lot more activity when it comes to diabetes.
And this is Connie. We're in an environment that's very different from a lot of states. Our Kentucky Employee Health Plan, it's been almost 3 years ago now, accepted diabetes prevention program as a covered benefit. So I, as a state employee, do have the opportunity to have DPP if I were to qualify for that. So it is almost, and we're hoping to see that it as a norm, as something that people expect. And as you know, once there is an expectation, then it's something that will be better accepted. The referrals is a huge issue, and we've been talking up DPP for 3 years. We're in the top 10 of numbers of states that have the number of programs, and for a small population of only 4.4 million, we're pretty proud of that, to be up there with the big states, with the larger populations. But again, and I'm a physician, I've practiced OB/GYN for 20 years, I can say that physicians don't change very easily. They change at about the speed of state government, so that's slow. But we are continuing to work on this. One of the other, and I took these points off of our state plan, we are working with our diabetes network in Kentucky and have started doing some inroads into faith-based organizations and getting talking points and church bulletin inserts and getting churches to actually have some screening programs. And it's very, 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 very infantile, but it is actually getting legs and being very well accepted. I paid money when I was in private practice to have a consultant come in and tell me how I was leaving money on the table, which hurt my soul to do that, but leaving money on the table was a phrase I never forgot. And we do have the ability, because of our Medicaid in Kentucky, our local health departments can bill for DSMES and are reluctant to do so, again, because many years ago they tried, they couldn't get billed, and so now it's that urban myth of you can't get paid for it. So we're doing a real robust push to get them to bill for what's on the table, the work that they're already doing. Our diabetes team, which I'm extremely proud of, and I think the CDC feels the same way, has worked very hard on a lot of projects, but our STEM program, the state engagement meetings, was quite successful, and we did have a task force, the Medicaid MCO task force, and that is we're going to rekindle that. We haven't had a meeting in a few months, but we're going to re-engage that group so we can figure out what other specific barriers do we have in Kentucky. And one of the things that we'll talk about later that Stephanie will address is, out of that meeting, one of our strong advocates came up with the idea of getting the legislature to pass the resolution, and Stephanie will tell you what's happened with that. But that STEM group was an interesting group that we had not pulled together before, from several different walks of life, different companies who are actually doing DPP and the successes they have besides our Kentucky Employee Health Plan. On the next slide, I will address the second point, which is development of strategies for our diabetes biannual report. Kentucky was the first state to legislate. We had to do a diabetes report, not just coming out of our diabetes program, but this was supposed to come out of our a collaboration between diabetes, Medicaid, our Office of Health Policy and the Kentucky Employee Health Plan. So we got together and said, why are we here? Well, we're here because they made us be here, and then what we found was a great amount of synergy. All of us were working on diabetes, and that's actually how the Employee Health Plan decided to say, hey, this looks to me like this would truly save us money, and we've instituted it in our Kentucky Employee Health Plan. But what we decided, and because one of our team members, her background is in marketing and sales, is being very helpful as we look at this diabetes plan and say, now that we do all this amazing work, how do we get this into the hands and in front of the eyes of people that could really learn from it? And so that's part of our team plan, is how can we make this a living, breathing document? The first thing we did was we took a 96-page report and she made it a one-page infographic, which was a little bit mind-boggling to me, and it's brilliant. And so we are really working to say, let's don't do new things, let's just take what we're doing and make sure that the world is aware of all the good work that's happening in Kentucky. The other thing, bullet number 1, is it dawned on us in our meeting that we weren't having our chronic disease team meet with Medicaid. And there are so many programs that we do that it would be helpful if we could get those issues to the Medicaid population. So I'll turn it back over to Stephanie for the next slide.
So back in March of this year, our governor signed what is called a Senate Joint Resolution number 7. And I'll just quickly go over this and tell you where we are with it, because I think we're running out of time. But basically, it directed the Medicaid program, the Medicaid department, to study the potential impacts of implementing programs similar to what Dr. White was talking about, and that is the DPP program that's covered under the Kentucky Employee Health Plan. And so what we did as a department is we reached out to our MCO partners, because our MCO partners cover most of our lives. We cover just under 1.4 million people in Kentucky. And so we reached out and we said, please look into this and do this study. So literally just this week, those responses were due back from our MCOs. On Tuesday. We got those back, and there's a lot of support. There are a lot of great ideas, a lot of things that, more pilots that are in the hopper. Our very own Kentucky Employee Health Plan, Anthem, obviously would be able to do something fairly quickly. And so I think at this point, we have to turn this in and actually turn it back over to the state Senate by the end of this month and give them our findings. And we fully expect that from our perspective, we do want to cover this, and we just have to figure out, one, how to pay for it and how to make it logistically happen through claims. But we also, because there was a joint resolution, expect something to legislatively happen, most likely if we don't act on it. So I think that there's a general feeling between the Medicaid agency and the public health agency. I think everybody's in agreement that diabetes prevention program is effective and it helps and it will ultimately save money. So at this point, it's just a matter of time. So we're really excited about the work that we were directed to do through that resolution. And at this point, it's just a matter of taking all of the information that we've gotten from our managed care organizations and submit the report and kind of work on our end to get this as a covered benefit. And with that being said, I'm not sure. Did you have anything else to add about that? So I think we're pretty good on this end. If anybody has any questions.
Great. Thank you so much. Thank you, Jane, Teresa, Connie, and Stephanie, for those really informative presentations. So as noted, we will now open it up for a few questions at this time. As a reminder, please submit your questions through the Q&A function that Travis has up on the screen. So we did receive one question specific to the Kentucky team. How were you able to get the meeting with your Medicaid consultant? Is it something you did through the health department? So Stephanie and Connie, I don't know if you want.
Yes, I guess I'm a little bit, this is Connie, a little confused. If the question is how did Medicaid and Kentucky Department for Public Health get together, then that was part of the 1618 initiative, and picked up the phone and called Stephanie and said, would you be willing to work on this with us? The word consultant may have gotten a little bit confusing, and I apologize. When I was in private practice, I had a consultant come in and teach me don't leave money on the table. So we have not, as a cabinet, hired a consultant to work with. We do most of our consulting with our subject matter experts at the CDC.
Okay, thank you for that clarification. From both presentations, it really seemed that the quality team, as New Hampshire put it, was really important to advancing your work. For both Kentucky and New Hampshire, from your perspective, what were the key stakeholders that were helpful to include on your team? Would you add any additional stakeholders as you're advancing your 618 work?
This is Teresa from New Hampshire. Jane had to leave, so I will attempt to answer this one. I feel like we had the perfect players on the team, and even if Medicaid was really working hard at the same time as our 618 initiative, they were working hard on the reprocurement process. So they were pulling double duty in terms of trying to move their projects along. So to have Jane there as a champion on that end, and then have Henry Lippman at those monthly meetings that the medical advisory board met on a regular basis. That was great communication with our bureau chief, Cy, and Cy is extremely well versed at communicating everything to Donna and to myself. And then I had the whole team of the private-public partnership behind these efforts too. So in terms of bringing anybody else on board, I felt like I could reach out to anybody I needed to. I didn't feel like I was missing anything, and I felt totally supported between CHCS, their TA, and their challenging questions that made us do that little extra homework that shed light on things that we were troubled in terms of trying to get an answer to.
And this is Connie from Kentucky. The group that we would like to bring in is our Kentucky Primary Care Association, which is the umbrella organization for all of our FQHCs. We happen to also be a part of an ASTO Omni grant for opioid overdose, maternal and child health, and ASTO added the Primary Care Association to that group, and it was a great addition.
Okay, thank you so much, and thank you again for your presentations, and thank you to our attendees for your questions. I'm going to take a few minutes now to tell you about a new 618 technical assistance opportunity. Next slide. We are very excited to announce a solicitation for both new and previous Medicaid public health teams from all states and territories to participate in another round of technical assistance, or TA, for the 618 initiative. Medicaid public health teams will be supported by CDC, CHCS, CMS, the Association of State and Territorial Health Officials, or ASTO, and other subject matter experts to implement interventions for one of 4 618 initiative health conditions: asthma, antibiotic use, high blood pressure, and tobacco use. Please note that technical assistance opportunities around preventing type 2 diabetes and unintended pregnancy prevention are not included as part of this opportunity. The National Association of Chronic Disease Directors and the Division of Diabetes Translation at the CDC will engage up to 6 states in type 2 diabetes prevention activities through a separate solicitation. Also, while unintended pregnancy prevention remains a priority 618 focus area, technical assistance is not available to support intervention implementation for that health condition at this time. States chosen to participate as part of Round 4 will implement their chosen interventions over a minimum of 12 months, with the potential for continuation for an additional 6 months of technical assistance. As all of the presenters have noted, there are many benefits to state participation in the 618 initiative. Beyond what was already presented in this webinar, I wanted to highlight some others, including building or enhancing cross-agency partnership through targeted capacity building, States, as part of the 618 initiative, will receive support from Medicaid and public health staff to enhance knowledge of each agency's critical role in improving health and healthcare and highlight opportunities to capitalize on complementary skill sets. Also, receiving targeted technical assistance to develop, implement, and assess chosen evidence-based prevention interventions that align with both state reform activities and goals, but could also improve health and control costs. And finally, learning from and sharing experiences with other states who are working on similar conditions or interventions. As part of your experience in the 618 initiative, Medicaid and public health teams will conduct a number of activities, including action plan development, which consists of cross-agency implementation planning and goal setting through the development of Medicaid public health team-specific action plans, targeted technical assistance that will be tailored to meet each team's unique needs and will include bi-monthly hour-long calls during the project period, peer-to-peer information exchange, which is comprised of as-needed group information, sharing calls and direct connections to peers through the 618 collab space, access to a wide range of health condition-specific and general 618 initiative implementation tools, templates, and other materials via CHCS's publicly available resource center for implementing CDC's 618 initiative, as well as a private 618 collab, a private online community created to facilitate sharing among and across cross-agency teams. And finally, an in-person convening in Atlanta, Georgia in January 2020 for Medicaid public health teams and past participants. Through the various items listed on the slide, teams should expect to spend approximately 10 to 15 hours developing their initial action plan and at least 1 hour preparing for each technical assistance call. The time commitment for activities related to implementing 618 interventions will vary, but please note this project does not include any direct financial assistance. Any state or territory interested in participating in the 2020-2021 cycle of TA to support implementation of CDC's 618 initiative intervention should complete the application available at the link here in order to be considered. We would like states to respond to the questions directly in the Word document found on the webpage and send the statement of interest form as an email attachment to CHCS no later than 5 p.m. on November 4th at the email address shown here. The information you'll provide will be used to select states and territories to participate in the 618 initiative TA opportunity. No identifiable information will be shared beyond the project team. On the webpage with the statement of interest form, you can find additional information about the project design, benefits, expectations of participation, and selection process. A team of reviewers will use the following criteria to select state and territorial participants. First, a commitment from the state or territory Medicaid director and public health official, as well as representation on the project team from both Medicaid and public health agencies. Next, capacity and state staff availability by representatives from both agencies to participate in one-on-one technical assistance calls and group learning opportunities and in-person meetings. Identification of the health condition and interventions the state or territory would like to address, along with a clear and compelling description of the goals, barriers, and relevant progress associated with the chosen condition and intervention. And finally, a past history of Medicaid public health collaboration and/or a current interest in fostering that partnership. The project timeline shows the steps in the state selection process. Completed statement of interest forms must be submitted by 5 p.m. Eastern Time on November 4th again. Selected states will be notified right before the Thanksgiving holiday by November 22nd, followed by an orientation webinar for the selected Medicaid public health teams. There will be an in-person kickoff meeting held in Atlanta on January 14th and 15th. Travel for up to 4 Medicaid public health team members per team will be covered by CHCS. I would now like to open it up again for questions to any of the presenters, or if there are any questions specific to the new 618 TA opportunity. Okay, so I'm seeing one question about the technical assistance for diabetes, and as noted in my presentation, the opportunity listed here does not include diabetes as a health condition. That technical assistance will be provided by NACDD and DDT at CDC. And there is another question about the continuation of the 618 initiative past this current year. While we are fingers crossed about the sustainability of 618 initiative for new states, this current round of TA is limited to 12 or 18 months, depending on the length of TA you wish to receive. Okay. And then there is a question about the level of representation on the state team. So these efforts are targeted to state public health and the state Medicaid agencies. And as part of participation in the initiative, we do require participation and commitment from both state agencies. Other partners are up to you in terms of who you would like to involve as part of your Medicaid public health team. But in terms of the required level of participation, we do ask that the state Medicaid and state public health teams, public health agencies are involved in the initiative. Okay. There is one question here for presenters from CDC and CMS, actually. How can state agencies leverage or incorporate ongoing work from your agencies into their 618 activities? So Kristen and Deirdre, do you want to take it away here?
This is Deirdre from CMS. Can you hear me?
Yeah, we can. Go ahead.
Yeah, this is probably better. I don't know if the writer has something specific in mind, and maybe they can send an email in follow-up if this doesn't get to it. But if you have activities underway with one of our agencies related to one of these conditions and you want to build on those or expand, I think we'll be happy to, if you're accepted to participate, work with you to align and streamline those activities in whatever way is possible or makes sense. So I don't know, some people may have seen that CMS recently announced an asthma learning collaborative, and we're in close communication. CDC is a key partner with us on that around how should folks come in to want to work on asthma, for instance, as a topic under 618 and be accepted. If it makes sense to align that with the asthma learning collaborative that we're running out of CMS, we will figure out how to do that to make it a streamlined experience for you as the state. So hopefully that helps answer the question, and if not, feel free to try to address it over email.
Thanks, Deirdre. Kristen, any perspective from CDC about leveraging 618 into ongoing work?
Thanks, and I'm not sure I have too much to add other than we certainly support the connection, and we're definitely seeing where states are using this ongoing collaboration across Medicaid and public health to make decisions, to help frame, using their data and together in terms of decision making, and able to, provide support to decision makers like governors and legislators, as well as using their partnership to think about some of the other priorities that their state priority health issues in that state that are outside of the 618.
Great. Thank you so much, Kristen and Deirdre. And thank you to all of you again for your questions and your thoughtful participation in this webinar. And I wanted to thank all of our presenters from Robert Wood Johnson Foundation, our partners with CDC and CMS, and from New Hampshire and Kentucky Medicaid Public Health teams. I see that there's a couple questions that are also coming in. We'll try to reach out to you or post an FAQ document about some missed questions. But we will be sharing slides after this webinar, so just wanted to make sure you all are aware of that. And if you do have any additional questions about the solicitation specifically, you can also reach out to Alyssa Beers at the information here. And finally, you can also find more information about the 618 initiative on CHCS's Public Resource Center for Implementing 618 initiative. And with that, I'll wrap up. And again, thank you to everyone for participating in this webinar. And please take a few moments after the webinar to complete the evaluation survey. Your responses really help us develop the most effective and useful learning opportunities. So thank you, everybody, and hope you have a great afternoon.